Welcome to the Neuromodulation podcast, presented to you by the International Neuromodulation Society. Dive into the forefront of today's emerging neuromodulation techniques, insights, and ethical and clinical applications. Subscribe now to join the multidisciplinary collaboration of medical care providers, scientists, and engineers who are part of the global conversation that's shaping the future of healthcare. Welcome to today's episode of the Neuromodulation podcast, presented by the International Neuromodulation Society. I'm today's host, Mandy Soleil, and I'm honored to be here with Dr. Alexios Carayannopoulos. Dr. Carayannopoulos is the Chief of Departments of Physical Medicine and Rehabilitation at the Rhode Island Hospital and Newport Hospital, as well as Medical Director of Outpatient Physical Medicine and Rehabilitation at Rhode Island and the Miriam Hospitals. He is Chief of the Division of Physical Medicine and Rehabilitation at Lifespan Physician Group and an attending physician at the Norman Prince Spine Institute. Dr. Carayannopoulos is also a full professor of neurosurgery and neurology and a clinician educator at the Warren Alpert Medical School of Brown University. He is board certified in both physical medicine and rehabilitation, as well as in pain medicine. He completed his residency in physical medicine and rehabilitation at Harvard Medical School and his fellowship in pain medicine at Dartmouth Medical School. He earned a master's degree in public health from Johns Hopkins University and certification in medical acupuncture from Harvard University. He spent 13 years as a U.S. Navy diver and submarine officer and is a specialist in undersea medicine and radiation health. In addition to being the leader of the INS Young Neuromodulators Committee for the past 5 years and being instrumental in the development of an international mentorship program for neuromodulators, he comes backed with many other accolades, which you can view in our show notes. And with that, I'm honored to welcome Dr. Alexios Carayannopoulos to the show. Welcome.
Thank you, Mandy. Good morning.
Good morning. To kick things off, you've published the book, Comprehensive Pain Management in the Rehabilitation Patient. I'm curious, how did you get into that field, and what motivated you to write a book on the subject?
The book is really a reflection of my training and my interests. Rehabilitation is essentially physical medicine rehabilitation, which is my primary specialty. And I did a pain medicine fellowship, as you indicated. And there are very few, if any, books or texts that combine pain management in that cohort of patients. In the pain medicine community, which is predominantly where I work, the majority of patients come in for an acute or a chronic problem. It's addressed and the patients move on, or they become patients in a practice. Whereas in a rehabilitation setting, which could include an outpatient or an inpatient, there is a dearth of information about how to manage this often complex medical and rehabilitative patient population. And so my goal for writing that book was to provide a resource. And these patients, whether they be chronic pain patients from failed surgeries or complex regional pain syndrome, through other more core rehab diagnoses like traumatic brain injury or spinal cord injury or stroke, there are instances where pain limits their ability to improve their overall function. And so this book is designed to give the provider a resource, give the public a resource on how to manage these pain cycles.
Makes sense. And neurorehabilitation in itself is an evolving field. You wrote your book in 2018, is that correct?
Correct. It's in need of an update.
For our listeners who may be new to the topic, can you share a bit more about what neurorehabilitation is and how it relates to pain care?
Neurorehabilitation is essentially recovery or rehabilitation, meaning improvement in the function, quality of life of a patient who has had a neurologic injury. That could be a stroke, that could be chronic pain, that could be a spinal cord injury. So the various diagnoses which are outlined in the various chapters of this text look at a larger population of patients who have had some traumatic or degenerative neurologic insult, meaning that they've had some injury. And rehabilitation, it's a multidisciplinary method of improving the patient's ability to do things, whether it be simple tasks like brushing your teeth, combing your hair, getting dressed in the morning, through more complex tasks like doing bills, driving in a car, doing your taxes, things like that. And in essence, the subset of patients that are often in acute or subacute rehab settings have some neurologic trauma that prevents them from functioning as they did before the injury. For instance, a stroke patient, depending on the sequela or the manifestation of the stroke, they may have a difficult time communicating. They may be aphasic. They may have a difficult time comprehending, or they may have an upper extremity that doesn't work the same way. So you literally can't fill out a checkbook or get on the computer to do your e-bills. So neurorehabilitation is a subset of a continuum of care that includes acute pain management, whether it be through surgery or medications or injections, all the way through an outpatient clinical paradigm where you're seeing a specialist in the outpatient setting, meaning a physical therapist, an occupational therapist, a social worker, speech language pathologist, to help you improve your functional gains in the long run.
You've brought up a good number of different types of professionals. Can you share what the multidisciplinary care approach looks like for neurorehabilitation?
Sure. There are two words that need to be understood a little bit more, and that's multidisciplinary versus interdisciplinary. Multidisciplinary means the collaboration of multiple specialists, whether that be a physician specialist, which includes a primary care, a subspecialist, a speech language pathologist. And they're people that help with everything from having a patient improve their ability to swallow or comprehend or communicate. Occupational therapists, physical therapists, they deal mostly with improving your activities of daily living and your ability to function, whether it be at home or at work. You have behavioral specialists, psychologists, neuropsychologists. You have social workers who can help the patient to transition from a place where they were independent to a place where they're dependent on either another provider or the medical system or their family. And the combination of these different disciplines is what is used to best care for these types of patients. I myself am a very well-trained physician, but I'm not a specialist in physical therapy. I'm not a specialist in occupational therapy. And the combination of these different disciplines is the right thing to do for the patient. Now, in the rehabilitation world, there's a little bit of a caveat there. We use the term interdisciplinary, and that means that you can have a bunch of specialists in the community that are working with one patient. So say you have a seizure disorder and you see your primary care doctor for your medical needs and you see your neurologist for your medical needs with relation to the seizure. They may not be communicating. And in the ideal situation, our medical system is predicated upon communication between all the specialists, given a number of reasons, whether it's time or differences in electronic medical records, what have you. There are multiple disciplines working on a case, but they sometimes don't communicate. So in the rehabilitation world, we use interdisciplinary, and that means we promote active communication in order for the patient to achieve their goals. We have regular, we call them team meetings, and these often occur throughout a patient's inpatient or outpatient stay to make sure that they're making the goals that were preset, in part by the patient, in part by their diagnoses, what the capabilities are, and also by the team. And so we meet regularly to update on the progress of these patients. And that's important because you can change the course to change the outcome ultimately if you're all well informed and working in the same direction.
This framework makes a lot of sense.
I think it's important to note that this is not a new paradigm. And in fact, it's been used for pain management for a long time. John Bonica, who is an anesthesiologist, he was one of the founders of the multidisciplinary approach in pain management. And there's a nice segue between rehabilitation medicine and pain management, because ultimately they both rely on this employment of multiple specialists to do the job. In terms of a particular scenario, I've had multiple patients whereby their communication needs are hampered, whether that be from a stroke or traumatic brain injury, and they cannot communicate their needs, especially at the outset. And one of the most important things, whether it be pain management or in physical medicine rehabilitation, is setting expectations and goals. And that's ever more important in the field of neuromodulation, because if you have a patient who has a realistic goal to say, be able to walk to the mailbox or pick up their grandson or whatever, it needs to be individualized for that patient. If the provider or the provider care team has an expectation that's different from the patient, then there's a problem. And at some point during the care continuum, there'll be a breakdown, and then either the provider won't meet their goals or the patient won't meet their goals, but ultimately it affects the patient and their ability to live, their ability to sustain a quality of life that's appropriate.
So where does neuromodulation fit into all of this?
Neuromodulation is a very useful tool. It is used to, in part, diagnose sometimes, but mostly to treat traumatic neurologic injuries, or sometimes now with degenerative issues like chronic low back pain, the new diagnosis for neurostimulation, it's important that you address the pain to be able to improve their function. For instance, there are patients that I see in my Spine Institute clinic that have chronic back pain, or they even have an acute back pain episode, and they're sent to physical therapy first before they see the specialist. They haven't had any imaging, they haven't had any medication management oftentimes. They're sent to the physical therapist de novo. One of the problems with that paradigm is that their pain hasn't been controlled. They don't get the most out of the therapy or the treatment plan because they're in too much pain. They can't bend, they can't twist, they can't make appointments because they can't get out of bed. The same thing applies to the use of neuromodulation. If you use it in a vacuum, meaning you're just using it as a treatment, if you're just using it as a treatment option without looking at the general and broader status of the patient, meaning what they're able to do, what they're not able to do, what their pain level is, and how you're going to sustain those beautiful gains that you get from doing a spinal cord stimulator implant or a peripheral nerve stimulator implant or even DBS, then those gains won't last, unfortunately.
Could you give me a rundown on what procedures and devices are incorporated into pain care in the neurorehabilitation space?
Oftentimes, the specialists that are dealing with the neurorehab component or the rehabilitation component aren't necessarily the specialists who implant the neuromodulation device. And that's fine. That speaks to the need for communication. And that also speaks to the need for understanding from both sides what the expectation and the goal of the patient is. Because oftentimes the patient is caught in the middle. The neuromodulator may have an assumption that all their pain is going to go away. And they're going to go after they leave their office, after the surgery, after the post-op, they'll never see them again because everything is great. In fact, what we've found in the neuromodulation world is that these patients will often get an excellent treatment from a trial, and whether a trial is even necessary anymore is up for discussion, up for debate in many spheres. They do really well with the implant, say for 3 or 6 months, but then they're lost to follow-up. And during that time, even though it would seem that they're doing fine, the assumption is they're doing great, they haven't seen me back. They're starting to really deteriorate. The stimulator isn't working and hasn't been reprogrammed. The patient hasn't really been educated about the changes in the way the stimulation is received over time. The need for ongoing education, sometimes imaging to make sure that there hasn't been any change in the system or where the device was placed. These are all things that affect the ultimate outcome of what we do as neuromodulators, and ultimately, and most importantly, the patient's outcome and where they reside, where they end up in terms of living their life with a neuromodulation system. Does that make sense?
It does. For our listeners who aren't familiar with a device implant trial, can you explain what that process looks like?
Sure. So one of the common diagnoses for pursuing neuromodulation or spinal cord stimulation therapy, neuromodulation is a larger term for dorsal column stimulation, peripheral nerve stimulation, dorsal root ganglion stimulation, and there are some other more percutaneous or transcutaneous type systems that are now coming into light. Ultimately, before implanting a system, whether it be a system that's implanted in the body, or now there are some more remote systems whereby the driver or the electricity that's supplied to the system is external. We have a lot more options now than we ever did. But essentially, you're assessing the patient for the appropriateness of therapy. That's the most important part. Whether the therapy is indicated, whether the patient understands what the therapy is going to do and has realistic expectations about what it could do, whether or not there are any medical or surgical contraindications to pursuing this type of therapy. And that begets the need to really explain the phases. Ultimately, when the clinical assessment is completed and there's a concomitant behavioral assessment to make sure the patient understands what they're getting themselves into, they don't have any areas of mood disorder that could impair their ability to recover or to perceive relief, then the question is, okay, let's try this out. And one of the advantages for neuromodulation traditionally is that you get a trial run. You get a test to see how well this will work in this patient this time. So again, traditionally, say a spinal cord stimulator, which is just one of the modalities that's used, you would do a percutaneous trial. During a percutaneous trial, the system, which essentially involves an electrode, and that's what directly stimulates the spinal cord, and some accessory things like wires that go to a battery and things like that. A percutaneous trial involves temporary implant of the electrode, the system that's required to temporarily implanted in a way that will give the patient information. We often will put these devices in the spinal canal, and the epidural space is the actual anatomy. There's a wire that comes out through the skin and is attached to an external battery. And whether that battery is adhered to them or operates through a radio frequency system, meaning that they don't actually have to have a battery or anything stuck to them, the system or the generator, the power source, is external. And in many practices, it's a 7 to 10 day trial. In different parts of the world, it's a longer trial, sometimes up to 2 weeks. In other areas, even within this country, it's a shorter trial, whether it be 3 days or 5 days, or there are even instances where you do a trial on the operating table for medical issues that need to be addressed or that would be of concern to protract this sort of treatment paradigm. So essentially, the trial is an opportunity for the patient and the provider to assess what their response will be. And there is a lot of subjectivity in the trial, and that's why there are instances where we wonder if the trial is even necessary anymore. But that being said, a trial is performed or not after an appropriate clinical workup, and then the implant occurs. And the implant can occur in an office type setting, in a surgical type setting, or some hybrid in between. And that should include a recovery phase as well as a planned follow-up phase. So whether that be a 2-week follow-up to assess the surgical site, and then a 1, 3, 6, 12 month, whatever the protocol is of the practice, there needs to be appropriate follow-up to make sure the device is working. Again, to make sure the patient understands all the nuances, the bells and whistles of the device. And not all patients will have the same capability. Some patients just want one of these devices to have an on-off switch, essentially. Others want to get into the minutia and understand how the system delivers energy, how they can change it. And we assess that to make sure that the patient is given the opportunity that they need or they want to have some locus of control. And that's often what will break the pain cycle. Giving a patient the opportunity to feel better, but also to have some control of their body, to be able to change the settings, whether it's the on-off or the volume, how intense the sensation is or where it is, or how you can change it during the day or based upon activity. That's the phase where the rehabilitation comes in very importantly, because once the system is in place and it's healed, you want to give the body the opportunity to scar in place. Then there needs to be a transition back to some level of activity, again, based upon the patient's goal set. If their goal set was to walk more, be able to walk in the mall, then there would be a gradual resumption through guidance, physical therapy, occupational therapy, the provider giving a home exercise program, something that needs to be individualized for that patient. And there need to be appropriate follow-ups to make sure that they're maintaining those gains. Sometimes, if you don't follow up on these patients, something can happen clinically, whether it be related to the system or not. So say a system is put in, and everybody has a different healing. So some people would heal in, say, 2 months. When the system is scarred down, we want the system to scar down because we want it to stay in place. Some people may not fit that. If they have some other medical issue, if they get into an injury, they have a car accident, or if they fall, some of the components of the system may have moved. And when those components move, that will change the way the electricity is driven, the way that the nervous system interprets or is able to manage that electrical impulse. Those patients need to be further assessed in person, sometimes radiographically, to make sure that nothing has changed. In other cases, there may be a change in the trajectory of pain relief because something else happens, not related at all to the stimulator. Say they have really poorly controlled diabetes. They get into an episode where their blood sugar goes way up or way down, or they have some other medical issue. They have a heart attack. They have some rheumatologic condition, and you have a spike of, say, psoriasis. All of those things can come into play and affect the outcome. And that, again, speaks to the importance of communication between the various providers.
Makes sense. I got a little hung up on you mentioning the importance of the ability for patients to have control in their own care and their recovery process, and the access to control being really pertinent for healing. And gives me thoughts around accessibility in general to these devices. Can you share, be it on a global scale or even within the United States, how does accessibility to these devices look based on where you live, maybe economic status? What can you share about that?
It's a really important point. So I feel fortunate. I live and work in the Boston metropolitan region, and there's a lot of very well-established and very well-regarded academic medical institutions, and I work at one of them. But for some people that may live in a rural area, or they may have an insurance issue, they don't have the same access to not only the neuromodulator, but also to the primary care physician. They don't have the ability to have regular follow-up. They may live 3 hours away. They can't drive because they have a visual issue, or they have a financial issue, a barrier, or they have a cultural issue. So the social determinants of health really come into play with any type of therapy, but especially neuromodulation. When your access to care is limited by these other reasons, then that often speaks to the chronicity of pain. If a patient who has what maybe you or I perceive as a minor injury, but it goes untreated because they can't get to the provider, they can't get to the hospital, they can't get to their primary care, they can't get to a physical therapist, and that pain can get compounded not only by time, but loss of function, loss of power, loss of strength, loss of the ability to feel like you're in control or know what's going on. The anxiety of not knowing sometimes, say, what's going on with me? I can't walk. I'm limited, and I wasn't limited before. That can really affect the ability for the patient to move forward. And it's the job of the care team to educate, oftentimes to reassure, put them in the right track. So again, getting back to your question, in the United States, whether it's a geography or a clinical scenario, access to care is key. Insurance is key. Some subspecialists don't take all insurers. Our insurance system in the United States is facing a lot of challenges. It was before, and with the COVID crisis and with staffing, with burnout, these are all affecting the care that we give as providers, that we're able to give because of our internal limitations in a medical center, even in an office. If you're living overseas in a rural area or in a country that doesn't have access to what we would call modern care, then you're going to be at an even greater disadvantage. Because even if you do have access, say you live in a country that's very poor and they don't have socialized medicine, even if they do, there are limitations on what that medical system will give you access to. You can live down the street from a doctor, but that doctor doesn't have access to neuromodulation. They don't have access to a subspecialist. They don't have access to a pain management specialist. They don't have access to a neurosurgeon or an orthopedist or even a physical therapist. That will limit the patient's ability to get into the system.
You mentioned cultural barriers as well. Can you speak to what some of those barriers look like and perhaps how cultural differences influence how family systems and communities contribute to the rehabilitation process for patients?
Sure. I can only speak to my own personal experience as a Greek American, but also what I see in other patient populations. Whether there's in some cultures, having pain means showing a vulnerability. And whether that's gender-based or culturally based, hard to say. Whether it's because say it happened to the provider of the family, whether it be the mother, the father, the grandparent, there may be a fear of being vulnerable or showing that you actually are vulnerable because you can't go to work, you can't provide for your family. And there are some cultures whereby communication is very limited, or expectations of communication. Being able to discuss some of the important things that are needed to understand the patient's clinical scenario. For example, sometimes just the physical examination. There are some cultures that would be concerned by having a male provider physical examine a female patient without a chaperone or what have you. That can be managed. But there are other situations where the patient, who again, may be male or female, whatever culture it is, it's difficult for them to speak up because that's not what their role is. They have a different defined role at home. And within reason, it's really important to try and understand where everybody's coming from, how we can help in a respectful way, how we can intervene that will help them. The last thing I'm going to do is to try insert myself into an equation. Well, I have the best plan for you. I'm going to put the stimulator in you, then I'm going to send you to rehab, and you'll be great. Again, if you don't understand whether it's a cultural barrier, a communication issue, whether it's language, whether it's gender, sexual orientation, what have you, all the DEI type things that need to be considered in our treatment planning, then something is going to go awry. An opportunity will be missed.
When we bring neuromodulation back into the picture, would you say that there are any limitations in that respect? Are there families or communities you've come across who don't want to have a device implanted, or maybe surgery is a limitation?
Absolutely. That's a great question. For some patients, going to the doctor in and of itself is taboo. They don't trust the medical system. when you walk into a room, nothing to do with you or your presentation or where you work. There could be a resistance to anything you have to say. And there speaks the need to develop an appropriate doctor-patient relationship. There needs to be trust involved, and that takes time. I think for any neuromodulator going into a new patient room and saying, I have the solution for you, you're going to be a great candidate for stimulation, we'll see you for the trial, we'll see you for the surgery tape. For some people, that's what they want. They've sought out your care, they've looked up your bio, they know your level of experience. But for other patients, whereby this treatment may be a great option, you need to go slower. And you really need to gauge that by your interaction with the patient's family, by getting to know a little bit about their home situation, their social situation, their demographic profile, where they live. I take care of a fair amount of patients who are in the prison population. And there are limitations in terms of access to care that need to be considered, but also the home environment, meaning the prison, where a neuromodulation therapy would need to be taken into consideration very carefully. That also occurs with patients who live in a behavioral setting, whether they're homeless or whether they live in a halfway house. One might think that these aren't ideal candidates, but if they go through all the appropriate clinical workup, the radiographic workup, the behavioral workup, one might step back and say, part of their issue with their depression or their anxiety may be due to the fact that their pain isn't well controlled. With, again, appropriate multidisciplinary approach, talking to a behavioral specialist, talking to the patient, talking to the environment or the family or the caretakers, these types of issues can be addressed, but it's all about communication.
The last time I went to my own doctor's office for my regular checkup, I had my physician ask me where I was working. Basic patient rapport. I mentioned the International Neuromodulation Society, and he had no idea what neuromodulation is. When even our medical professionals aren't aware, how do you go about educating patients who are going to have varying degrees of understanding of this rather complex practice?
It's a very important question because we spoke before about access to care. In our own country, and we think we have a very advanced medical system, as you indicated, there are primary care specialists who have no idea what the subspecialists do. And that doesn't just pertain to neuromodulation that I do and my colleagues do, but it could be some other minimally invasive surgical approach to appendicitis or to whatever clinical or surgical indication. So again, there speaks the need for communication. And it also speaks to the need for advocacy. It's important that as providers, we advocate for our patients. And that may just mean calling the primary and say, hey, I saw your patient. This is what I think. These are the options. What do you think? Or that may also mean working on a committee, say of NANS, a subcommittee or a committee that looks at the insurance challenges or the political challenges that are affecting a patient's access to care. That's something that we can do as well. Whether it be the patient that advocates for themselves. Say they go to this appointment, they have a great rapport. After a while, they want to go down the path of neuromodulation. It makes sense for them, but their family is resistant. That's an opportunity for them to educate their family or to draw on the care team so that we can help. Again, from my perspective, it's all about understanding the patient, understanding where the patient is at that time, where they come from, what they're thinking, where they want to go, but also understanding the limitations, whether it be through education, language, communication, social status, access to care, all these things that we've mentioned. That's the way that we're going to be able to promote getting the word out.
For listeners who might not be aware, NANS is the North American Neuromodulation Society. Moving on from that, I'm really curious to hear about advancements in the field. I know you have a personal interest in artificial intelligence. I do as well. I'm curious how you think AI is going to influence the future of this field and patient care.
It's a great question, and I think very timely. Artificial intelligence has been taking over. AI, or artificial intelligence, is in the news all the time. We're hearing about the good things, the bad things, and I think for myself, it's helping me to understand how much I don't really know and how much the majority of us don't know. Mm-hmm. There are some neuromodulation systems that are existing today that use artificial intelligence, and I think they're paving the way for others, other companies, other parts of the industry to keep up or to exceed, but also for us to challenge the way we think. So artificial intelligence is complex, but essentially it's based upon data. And data is key, not only to making sure outcomes are the best they could be, but also being able to know when they aren't. with artificial intelligence, the idea would be to target the right patient using the right treatment at the right time. And whether that be driven by a protocol that's based upon data that's collected among similar patients that would predict how a patient who has this demographic, this clinical diagnosis, this whatever would fare, or whether it's based upon actual data that's there and comparing it to others, artificial intelligence can help us to be better clinicians, can help the patient to be a better patient, to have a better fit between the provider, the patient, and the care team, to predict the needs of that particular patient, which may be different than another patient having the same type of therapy. And ultimately, it will make our system better. It'll make the patient better. It'll help to make the system, our medical system, more efficient. But then there are a lot of concerns that we have, whether that be to the ethics of it, the ethics of collecting data, or the ethics of predetermined clinical paradigms that may not be individualized to that patient, but based on a larger data set. There's just so much that we don't know, but it's here. And the more we understand it, the better we'll be.
That's fascinating. Do you have any other sentiments about how you envision the future of neuromodulation and neurorehabilitation evolving in the years to come? And actually, I'll add a caveat to that in case you have any contribution. I was just reading the other day, San Francisco, the hub of artificial intelligence, invested in 2023 $11 billion into AI. Are there particular areas in your field where you think more investments would be valuable?
Absolutely. And I think there's a burgeoning applicability of AI to healthcare. And trying to understand the options, I think it really boils down to the basics. What can we do using AI that would help us have a better interaction with the patient? So instead of going into a new patient visit and having the provider who has to sit at the computer and put a bunch of data into their EMR that's required for insurance or documentation, what have you, but using AI to have a one-to-one conversation where there's a communication device or a listening device in the room, and obviously the patient would have to be consented to that, but that allows the patient and the doctor to sit and talk. So even if it's a 10-minute appointment, if it's a 20 or 30-minute appointment, even better. But if you have face-to-face, eye-to-eye contact, you can relate to one another. And you can often get information that's more salient to the clinical scenario. And that's using data from whether it be other patients in the same situation or approximations or mathematical modeling. It'll help the clinical interaction. Now, when it comes to the treatment, you can use the same idea. If we have data that shows that this patient at this time who presents with this clinical scenario and this other stuff, whether it be medical stuff or psychosocial stuff, how they will do, that might take us on a different trajectory. That may say, this is a better patient to get involved with behavioral management right away, or physical therapy right away, or to go right to a surgery based upon the clinical and radiologic need and application and how that particular patient would probably do. I think it'll help to better triage. And then, of course, when it comes to finding the right treatment, AI can also help us to longitudinally monitor patients, whether that be through the patient using a portal or a device where they record their pain. And there are some really great pain apps now that give the provider and the care team the ability to have more of a real-time communication. These types of things can help our outcomes in the long run. We just don't have the power right now, the time, the knowledge to make sure that all of these things are in place. But AI is often smarter than our capabilities now, whether it be AI driven solely or the combination of artificial intelligence with the human being driving it or monitoring it or regulating it. Time will tell, but there's tremendous opportunity. I'm trying to stay really positive about it. And I know there are a lot of people who are fearful. One of the other things that occupies my time is I'm highly invested in medical regulation. So I sit on the medical board for my state, and I'm very active in some federal, national, international society work, et cetera. And the need for patient safety is one of the concerns with AI. Ultimately, as physicians, as providers, we take an oath, do no harm by the patient. We want to make sure that AI knows enough or has the ability to discern which treatment is best for that patient. From my perspective, there's always going to be a need for the human to interpret what the data is giving them.
Mm.
But that speaks to the art of medicine.
Thanks for that. That's great. So we're at time here, but I want to say, do you have any final takeaways for our listeners today before we jump?
I'm thankful for this opportunity. I think whether you be another clinician or a member of the public, a patient, there are good options now to treat pain. And whether that means the actual option, the device or the surgery or the medication or the treatment plan or the combination of ideally multi or interdisciplinary care, I think the future is bright in pain management. But I think we need to continue to work together collaboratively. I think we need to collect data. We need to compare stories or share data in order for us to keep moving in the right direction.
Sage words. On behalf of the International Neuromodulation Society and the Neuromodulation Podcast, it's been a pleasure to have you here today. I want to really thank you for your time.
Thank you for having me.
And for listeners out there, we would love for you to take a moment to subscribe to the show, and we look forward to catching you next time.